Yes.
Okay, so everybody should have this document here. Can you see?
Would this be found
Or
in
do you see? Or do you
in our
see?
email?
I'm sorry.
I'm sorry, would this be found in Canvas or in our email?
So you guys should have gotten this email to you. I believe Ms. Z sent this to you a while ago.
Yes. I received that one. Let me
Great.
look.
You see
Yeah.
this? You see the brief RAM assessment data collection sheet? That's what you should see. Does everybody see that brief RAM data collection sheet on my screen?
Yes.
Yes.
Okay.
That's my friend's name.
The RAM assessment, okay. And what it basically is about is how the person adapts physiologically, psychologically, to things and changing in their environment, okay? So let's say I have pain. How's that going to affect me? It affects everybody different, right? Some people have pain and they act like nothing's wrong and they carry on. Some people have pain, they might get angry or mad. Some people have pain, they might cry. Some people might withdraw or be isolated. So that's your, let's say pain was your focal stimuli. How does that focal stimuli affect me in my environment? And that's what Sister Roy Callister really talks about. So from her perspective, as patients, we behave or we react to that certain stimulus. And an example of observable behavior, if you look at the bottom of your care plan, you have behaviors down there, okay? So an observable behavior would be something like the patient's pulse. That's something that you can measure, something you can feel, and something that you as the nurse can describe. So that's going to be your objective or your observable behavior. Your non-observable behavior is something that the person experiences and reports to the nurse. So like your pain, okay? And then, you know, how do we respond to those behaviors? Okay, so physiological is one of those modes, all right? Like if I have pain, physiologically, how might I respond? My blood pressure might go up, my heart rate might go up, okay? My respirations might increase, or the depth of my respirations might decrease, and I might breathe faster and more shallow because I might feel pain when I take a deep breath, as in the case of like a stabbing wound or pneumonia, I might feel pain when I take a deep breath. So it's going to change the way I breathe. The stimuli that we see are going to be three things, okay? Focal, contextual, and residual. And focal really is that immediate thing that confronts the patient. So for Edith Jacobson, what kind of things might be her focal point here? Well, if we talk about the physiological aspect, she broke her hip. So physiologically, she has a couple things going on. One, she might have pain, which she did have pain, right? She had pain 8 out of 10. We gave her some morphine and it brought it down to a level of 2. Psychologically, how is it going to affect her? One, she lives independently. So she's 85 years old. Is she even going to want to tell her family that she fell? Because what's she going to be worried about?
Them taking her independence away?
Exactly. Right now she lives alone, but if I tell you I fell and I got hurt, then you might take my independence away. And so sometimes the elderly will even lay on the floor for hours and not push that help button or call somebody, because in their mind, they might still think they can get up and move without letting anybody find out that they got hurt. So residual and contextual. Now, contextual is anything that could contribute to that focal stimuli. So like, as far as the pain, what contributes to that pain? Well, she's got a broken hip, that contributes to it. She's immobile, she's not able to transfer herself. So maybe if she can reposition and transfer herself, that could be a part of it. If you listed her focus or her focal point as falls, because right now falling is an issue for her, and she's falling, why? Because she's dizzy. So fall could be your focal point, and the dizziness, the osteoporosis, weakness in the legs, those things could be contributing to the fact that she's falling. Your focal point could be dizziness. And what's contributing factor there is, maybe medication changes, maybe the fact that she's 85 years old. So when she stands up, she might be experiencing some sort of orthostatic hypotension, things along that line. That's what tends to cause falls in the older people. Or sometimes because they have like neuropathies and stuff, they always don't know where their feet are in perception to space and time. So sometimes their foot, it's like when you go to step down on a step and you think the step is there, but where your foot lands and where the step actually is two different places. And so you end up falling because you miscalculate or you misperceive where that step is. So these things all can contribute to the patient's fall. Also, we see that the patient's stubborn, right? She don't want to use that equipment that they gave her to use to safely transfer herself or ambulate herself through the house. She's stubborn to using that cane or that walker. And a lot of people are. Like my mom will walk until, you're like, Mom, just use the scooter, just use the thing. Then you can keep up with everybody and go where you want to go. Oh, I don't need that thing. Meanwhile, we're trying to jump through hoops, trying to keep her safe. All right, just get on the doggone scooter. I mean, if somebody gave me a scooter, I'd ride it. But they're stubborn to that because it makes them, I guess, feel not as whole in some manner. All right, so residual are things that also affect the contextual and the focal aspect, but it's things that you might not necessarily be aware of that contribute to it. So like her osteoporosis could contribute to her falls and to her dizziness, and the medication she takes for the osteoporosis itself could also contribute that. She might not be aware that she's at a higher risk for the osteoporosis or for falls because of the softening of that bone, or because those bones aren't as good as what they used to be, okay? She might not be aware that because of her ethnicity, because of her gender, because of her statute, she's more at risk for these things. It could even be because culturally of her diet, because certain cultures, they eat certain diets, and those diets don't always correlate with healthy bodies. So that's your residual aspect. Anybody have questions on that part? Don't be shy.
Are you able to just
Somebody
like
else probably does, right?
hello?
Yes.
So the focal is like what she's experiencing there and then, like the main one?
Thing that's confronting her. What's the main problem that's confronting her at the moment? And what you perceive it to be versus what somebody else perceives it to be could be two different things. So what external or internal stimuli right now is causing a change in the way she's going to adapt to the environment? So here's the thing, we get sick, we have certain internal innate processes that try to help us adapt to that. And sometimes we can adapt and we can move along. And other times we really don't adapt well. So when is a time when people really don't adapt to that changing in their environment? So like I'm a type 2 diabetic, but I'm not taking my medication. I'm not exercising. I'm not eating right. So I'm not really adapting to that stimuli that has caused a change for me. So now what's happening? I'm getting gangrene in my foot. My diabetes is way out of control. I'm in the hospital all the time. I'm sick all the time. So in that case, I'm not adapting to what's going on, right? And it could be that I'm not adapting psychologically. But if I'm not adapting and I'm not compliant with the treatment, now it's affecting me physically also. So what happens is when we don't make that adaptation in all these areas, then it causes additional problems. So our job as the nurse is to identify this abnormal or this external stimulus that's causing the patient to change and find a way to help them adapt to that new situation in their life. So we do these interventions, one, to counteract whatever negative is happening to them, right? So like if my patient is developing an infection, I would do an intervention to counteract that infection so it doesn't happen. Then my goal would be to teach the patient how to also prevent that infection, because I'm only going to be there with the patient for a couple of days at most, right? You come in the hospital, you have an infection, maybe they put you on IV antibiotics, or maybe they do something oral and send you home. Either way, I got to teach the patient how to prevent that infection, because my goal is to help them adapt to what's going on. So I help them adapt. I promote that adaptive behavior by teaching them how to get the outcomes that we want. And our outcome would be to be free of infection, right? Because if the infection continues, then I'm going to lose that limb. Or it's going to go to my heart. It'll travel systemically. It'll break my kidneys down. It'll kill my heart. And I won't have to worry about the infection anymore. So, you know, we could be helping someone adapt to an acute problem and just get through it. This is going to play a bigger part when your patient has a chronic illness, because it's going to take more for them to adapt to that situation. Did that answer your question?
Yes, thank you. It's just a lot. So I'm just trying to like understand it more. It's also new.
So let's go back. Let me, can you guys see the care plan that I have up? Let me go back to that page.
I'm actually trying to find it in my, oh, okay, never mind.
Whoa.
So this is on another patient, okay? So let's just go through the components of it. So at the top, you know, you're just going to put your name. You can put virtual hospital. It doesn't matter. And you could use whatever date. It doesn't really matter. Okay. The client's initial code is going to be whatever the first and last name is. So yours is Edith Jacobson, right? So that's going to be EJ for her. The code status for this patient, Edith Jacobson, I believe it says in your case study that she's a full code. Now, why are you putting all this information here? Who cares what all this is?
So if anything's happened to her, we can pull that and know without having to ask anybody?
Okay, yes, it helps you to analyze what's going on with the patient so you can identify what nursing diagnosis you need to make to help this patient meet some of those goals to adapt to what their current situation is. So our patient's current situation is a fractured left hip, right? So that's going to be her primary diagnosis right there, is that fractured left trochanter, I believe.
Yes.
Then the PMH is her past medical history. So if she has any other medical history that was listed in there, you want to put that in there. If it's only osteoporosis, then that's what goes there. And then PSH is past social history, because this is RAM. So she looks at the physical mode, the self mode, okay? Also, if you go all the way down here to the bottom, it lists the 4 modes that she talks about. Oh, I think I took it off of this one. I might have it in another page.
It's physical mode, self-concept mode, role function, and interdependence.
Great, thank you. So, you know, the second one is that psychosocial component, that's self mode, okay? How am I accepting this as a person? And the third one was what? I'm sorry, tell me again.
Role function.
So when we talk about role function, how is her function and her role going to change? Right? It's already changed for her as she's gone through her life. And Erickson's talks about this a little bit. So if you notice down there on the bottom of the, down there about midway down the care plan, you'll see psychosocial, self-concept, role function, interdependence. So for a body image, you know, do you have in mind how this patient presents? You may or may not, okay, for the body image, but religion's there for you. It's in the case study, and you should be able to identify what her Erickson's stage is for an 85-year-old patient, okay? And then role transitions. So there's different roles that we play in life. We might be the primary caregiver, okay? We might be the maternal head of the house, the paternal head of the house, all right? We might be dependent versus independent, or right now, she's dependent now, right? Because she's got an inability to transfer herself independently. So that means safety-wise, she can't really be on her own because she's not able to transfer. If you're not able to transfer safely, that's like one of the things that you have to be able to do, that we would expect you to be able to do in order to safely be alone. So now she's transitioning from that independent role to that dependent role. That's her role function, right? How's that going to affect her mind?
Might be become depressed.
Okay, what happens when your mom comes in your house?
He tries to take over.
Yeah,
Tells
she
me-
takes over, right? Oh, you're not cleaning that right. You're not cooking that right. This is how you do that. And no matter how you're doing it, you could be doing it exactly like your mom does it. But she'll be like, yeah, this is how you do that. Because they like to be in charge.
Right.
When they transition into that dependent stage, you kind of take the reverse role now. And now you start to almost treat them as if they're the child, right? Mom, you got to take your meds. Mom, let me change your Depends. Mom, you need a shower. Oh, I'm not taking a shower. I just had one yesterday. I just had one 3 days ago. How many of you have dealt with an older parent or grandparent?
Me.
They're stubborn. And
Very.
they act so much like a toddler. They become just like a toddler in a sense, except that they're older and they're wiser, and you know, they get offended easily if you don't follow what their routine and their regimen is. And they have most of them have a very strict regimen. They're 85 years old. They've been doing it this way their entire life. So you're not going to change them now. So you have to accept and try to help them transition and adapt. Interdependence is how they function, you know, with other people, who their support systems are. So, you know, Edith does have a daughter. She is Christian, so one would assume that, you know, her church is part of her support system. If you look at the top,
Before you go further, for the body image,
yes,
don't know what to put. I don't know how to what to put on that section.
so you do not have any data in your particular scenario that goes to the body image for this patient. She could have a self-concept if she were to look in the mirror right now, because what would you expect to see if she has a fractured trochanter?
Well, if she fell, more than likely she might have bruising other places on her. Maybe her
Okay, and the
face.
hip itself is probably bruised too.
Yeah,
What else is the leg gonna look like?
swollen, probably out of place.
Swollen.
Okay, out of place, meaning that generally
Doing that.
that's broken is usually shorter than the other leg. It's also externally rotated a lot of times. So, you know, what kind of concept would she have in regards to that if she were to see herself in the mirror? Also, you'll notice when you go through the actual VSIM itself, which we are going to do in a little bit, when the nurse talks to her about transferring, she will tell you that she's not able to transfer herself right now. So what sort of body image would that give her? Would that affect your image of yourself if you had to rely on someone to move you all the time? It might be embarrassing for her. It might make her feel less of a person. It might make her feel like she's a burden. So a lot of emotions can go along with that when you have to rely on someone else to help you all the time. And you lose a sense of privacy, because now you can't even go to the bathroom on your own. You can't roll, you can't move. You can't, I mean, I kind of feel her right now. I'm in this chair with the broken leg. Okay, I have to rely on other people, you know, for a lot of stuff right now. And, you know, that can bug people sometimes. Other questions on that? Any questions on the self-concept, the role function, or the interdependence?
So in case you're writing what you found on the self-concept, like can it can it be like a full sentence, or it's just like you know, like you can bullet stuff? Like say for example, the way you stated that she has the hip fracture. So she might be embarrassed to maybe go to the bathroom and have somebody help her. So when you're stating and saying something about that, like, do you have to say due to the fact that she said this, or just state it?
So you could write something like, patient may be embarrassed due to reliance on others for, or due to inability to transfer self. Patient may be embarrassed due to inability to transfer self, because now she has to rely on somebody else, right?
So if she didn't say it, can we put that as a risk for, like risk for embarrassment due to not being
I
toilet
wouldn't
herself?
put it as a nursing diagnosis, but you could put it here, body image appearance, because
Oh,
an inference or a cue based on what you see by the patient's behavior. But it wouldn't be a nursing diagnosis. That's the difference. Here, right here,
Gotcha.
is not nursing diagnoses. You're just writing what you see in the patient, what you observe, what you feel the patient is experiencing. What is she showing you? Where's my focal? I think it's up higher. Okay, focal, conceptual, residual. Okay, so for this patient, the focal, this nurse gave as a safety concern and as a venous stasis wound. Okay, because what this patient has here is a wound that won't heal. All right, so the patient's not properly either taking care of themselves, the wound, or perhaps both. So that's why they made the focal point either the wound or safety. It could be either one. Really, you only need one focal point there, but if you want to put more than one, I wouldn't cite you for it, because what her focal point was previously compared to what it is now might have changed. All right, and then they made her conceptual here, safety awareness at home. So that could contribute to safety, because if she's not aware, one, there's definitely an issue there. She's not using the walker or the cane. She might also have throw rugs and stuff down if she's not following other safety issues. So that could help me as the nurse by prompting me to say, listen, maybe I need to went in to evaluate the environment prior to discharge.
Hafsat, you please mute yourself.
So I'm sorry. I'm so sorry.
I'm gonna put everybody on mute. If you want to talk, you'll have to chime in. All right. I didn't, but somebody went off, so I'm gonna leave it as it is for the moment. All right, so again, one of the focal points that this nurse gave to this patient was a safety issue, okay? Because the patient has a lower leg wound that's not healing. So they gave this person poor safety awareness at home. Again, if you were using safety for Edith Jacobson, poor safety awareness would be a good example, because you already know at home she's not following some of those safety measures and she can't transfer herself, right? So she's not using the cane and the walker like she's supposed to. She doesn't have the ability to transfer herself. So it's definitely a safety issue there. Instead of venous stasis wound, because Edith doesn't have that, the left hip fracture. Okay, it could be pain, it could be dizziness, because all those things she's experiencing. Again, she can have one focal point now, and then in a week, her focal point could be something different, because the focal point is what is immediately facing the patient, what is immediately causing them to change or adapt to their environment. So what's really going to cause her to adapt to this environment right now is that left hip fracture, because that's going to change everything for her. It's going to cause her to lose her independence. It's a safety concern. Okay, have to have surgery. She's going to have to go through PT, and she may have to give up her independence. So all those things are going to be an issue to her. Conceptually, again, what kind of things contribute to, if it was left hip fracture over there, what kind of things would contribute to that? So the osteoporosis can contribute to that. The dizziness could have contributed to that. The fall contributed to that. And then for residual, what kind of things could have contributed to that left hip fracture that she may not be aware of? So maybe the side effects of the medication she's on, maybe that made her dizzy and that contributed to the fall. Maybe the gender, the fact that she's postmenopausal contributed to that hip fracture and she's not aware. Maybe her height, her weight, her ethnicity, because if you're a certain height, weight, and ethnicity, you're more susceptible to osteoporosis, which contributed to the hip fracture. So these are things that may be occurring with the patient that they might not necessarily be aware of how it affects what's going on or why it affects. Again, questions about that? If somebody just asked a question, I definitely did not hear it. Okay.
I'm good.
Miss Sue,
Yes.
hello? Miss Sue, can I please get your Zoom information? I'm trying to log into my computer. The phone is not helping me.
Okay, my Zoom number is 849. I gotta look it up because I don't know it offhand.
Uh-huh.
Sorry, it's not being cooperative. Let me stop this share for a second. Okay, so you're filling all this stuff in at the top. I did on the right have to hand type in the blood pressure because it didn't have that option there. Again, if you use the word document for this, it'll be a lot easier because with the word document, you can manipulate it better than with the PDF version. All right, so RAM behaviors physiologically, okay? So for her, she didn't have a lot of changes physiologically. Oxygen saturation, okay, if she's not on oxygen, you don't have to put, see that says O2-LM. So that would mean she would be on liters. You would put like 2 liters there or 4 liters if she was on oxygen, but she's not. She's on room air. So room air and whatever the percentages goes there. And then how did those lungs sound? You already put your respirations at the top. Okay, because that's goes with your vital signs, so you don't have to redocument the number of respirations. And then your, cardiovascular assessment, your skin assessment. Most of that is in. I put most of this in the case study for you. So that case study that you got by email, you can get all that information from right there. All right, she doesn't have any wounds right now. She has a fractured hip and she's pre-surgical. She's going for surgery tonight, so she doesn't have any wounds. What kind of diet is she on? And if that's not on the sheet, you should be able to find that on the VSIM. Let's go there for a second. We're going to go through the whole VSIM, by the way. But I'm just going to show you something that if you want to get it out of there, you can. I tried to give you most of the information from the VSIM. Typically, we have you go right in the VSIM and get it out. But just to save you guys some time and make it a little easier, we put together that case study so you don't have to go back and forth in there to get everything. But it is something you would want to know is your nutritional status because your patient's going to be immobile. They're going to have a post-surgical wound. And so you're going to want them to heal. You guys see my VSIM screen? Or you still see the care plan?
The care plan.
Okay, see the VSIM page now?
Yes.
Okay, so a lot of information in there for you. And most of the stuff you already have in your case study, but a couple things that you want to be aware of. So the Morse fall scale, okay, that goes under activity. Like where it says bed rest and all that, that goes under there because she had a fall scale score of 45, which means she's at high risk for falling. So that's one of her things right there that she's got going on. 2, she's 85 years old and she's got a broken hip. So you're going to need to really reposition her a lot because as you get older, your skin's thin. It's you have a lot of bony prominences. And so this patient can easily develop breakdown.
Miss Sue, I have a question. So
Yes.
under, let me see, make sure I'm under the right thing on the care plan, where it says MMSE score, would that be the Morse false
No,
scale score?
MMSE is a mini mental status score. So if you were doing a mental evaluation on her, then that's when you would do that.
Okay.
And then I think I gave you guys the Glasgow Coma score. All right, so your Morse fall scale, that goes under where it says activity.
And can you repeat the Glasgow Coma score, please?
It's in your case study. Where's your case study that I sent you? From Ms. Z. You guys can see my screen with the care plan?
Yes.
So over
Yes.
left, okay, where it says range of motion, gait, all that, that's where inability to transfer independently and the Morse fall scale goes in here. And then over on the right, where it says MMSE, we didn't do a mini mental status, I don't think, evaluation on her. But the Glasgow Coma scale would go there. And that is in your case study that I sent you. I think it's a 14 or a 15, I don't remember. You guys didn't do any cranial nerves, so you wouldn't put that, you would just put not applicable. You should have a glucometer reading. You wouldn't have an endocrine assessment. And neurologically, you know, I want to know from your perspective of talking to this patient, how did they appear? And you'll see that in a second when we go into VSIM. A lot of times people don't put the urine output or the bowel movement, okay? Now, if you go into the patient's chart, which I'm going to show you that, it talks about her bowels and her urine. All right, that's always important. You always want to know what that baseline is before you're going to operate, and you're going to be monitoring that after surgery in case there's a change. All right, let's go back to the VSIM now. All right, so all this information's here for you. And then if you go down below, this is all in the pre-simulation part, or the suggested reading part, I'm sorry. You'll have all this other information. So if you click on any one of these green tabs, it'll take you about patient positioning, wound healing, pressure injuries, how to prevent them, the older adult. So a lot of information there if you need it for your care plan. Hip fracture, osteoporosis, and the medications that she's on, because you do have a portion in your care plan that asks you about medications and about nursing indications. So you're expected to document what medication she's on and what are some of those nursing indications for that medication. And then this talks to you about range of motion, about what you should do with the anti-embolism stockings, fall management, prevention, body mechanics. And then the last one is an assessment tool that we use on the older adult. So, you know, some of it can be helpful. You may not need or use any of it, but it's there for you if you need it. When you go through the VSIM, you're expected to do the pre-simulation quiz. You can take it as many times as you want. The VSIM itself, you have to get a minimum of 75. I encourage you to try to get at least an 80 on it. That's what I tell my evening students. I want an 80% on it because that tells me you really went through it methodically and you understand it. And it's going to help you as you do VSIMs in the future. All right, so once you go there, you can actually launch the simulation. And then you hit go see this patient. It takes you into the actual simulation. Again, this first page, can you see it? Yes, no?
Yes, we can see it.
Okay.
Yes.
So this first page here is again the admission report. And if you look at it at the bottom, it tells you exactly what you need to do, basically. All right. The nurse already gave her morphine at 2 p.m. Her pain level was 2 after the morphine. It tells you what the nurse did and then what you should do. So your job is going to be to reposition her, turn her every 2 hours, perform a musculoskeletal assessment, reinforce safe patient education on the fall risk, assessing the pain level, and medicating if needed. Other things you're going to look at is her other orders that she has. So if you were going to a real clinical, you would go into here and look at the chart first. Patient log isn't going to really have anything because that starts to log as you're actually doing these simulations. Come on. Okay, it doesn't want to click on it for me. Frozen. Stop for a second. Come on. Let's try it again. Not being cooperative. All right, let me see if it's going to let me go back into the patient's chart. There we go. Except that it's doing all types of crazy stuff. Okay, so you see that okay? See it? Hello?
Yes.
Yes,
Guys
we
can't
can
hear me?
see
Yes,
it.
yes.
Okay. All right, so this is the patient diagnostic test. Okay, and here, the only thing I can write from here is anything that's abnormal. I think I gave you a list of most of the stuff anyway, but if it's abnormal, it goes into care plan. So you would want to know all before you take your patient surgery. which is going for tomorrow.
So for Edith Jacobs, everything is normal.
So what's abnormal for her though?
I don't see any abnormal lab for her.
No abnormal lab. The X-ray was abnormal, right?
Yeah, except the X-ray, yes.
Okay, so the X-ray is the only thing that has to go in there because that was the only abnormal. All
So I
right.
need to put like everything was normal in the normal units.
So I believe on the care plan, let me go back to it. Come on, computer. It should say in that lab box that only to add the abnormal. This is your medication administration records. This is going to tell you what medication you're given. It tells you about the IV solution, which I think I already documented for you guys.
Miss
Dr. Morphine.
Suzanne, you're breaking, so I don't know if it's my internet or yours.
I'm going to log out and try to come back in. I'm going to assign somebody to host, and I'm going to log out and try to come back in.
Okay.
It must be my computer. It seems like it's freezing up. It's not even letting me go out. Hello? Can you guys hear me?
Yes, we can. I can hear you.
Is it any better?
Yeah, right now it's better.
Okay. So we try this again. Okay, so your radiologist is going to tell you about your x-ray, your orders here. You want to go through those because you may have to do interventions, all right, with the anti-embolism stockings and checking the IV. And then this is your eye and nose. This tells you the last time you had any input or any output. All right, and then after that, you can go into the actual VSIM. You want to start in safety measures, go through the chart. Come on. Stop it for a second, see if I can click it back on again. VSIMs don't like to work in the Zoom. I apologize for the technical issues in advance. While this is going around, anybody have any questions on what we went over so far in the care plan?
Are we gonna be doing another one of these reviews?
Yep. I'm recording this, so hopefully you guys should be able to see it. I did record the one last night also. Can you guys see the care plan again now?
Miss Suzanne, I think it's just your internet because you're still breaking.
Hold on a second. Okay, can you hear me any better now?
That's good now.
Okay. So I'm going down further while I'm waiting for that VSIM to work right because it's acting ridiculous. Okay, here's the medications. This is for a different patient, obviously. You're going to put the medications here that are for your patient. What are they getting? What are your nursing considerations for that medication? All right, put at least one there. Again, lab and diagnostic studies, I usually only put what's abnormal. As far as teaching and discharge needs, so this patient broke her hip. So what kind of teaching is she going to need?
Your screen is still on the VSIM, so maybe we're doing the care plan, right?
Mm-hmm.
All right, you're not on the care plan. I'm sorry, I'm a bother. Just want to understand this. Yep,
Nope, you're
thank
not a
you.
bother.
You're good. Now you're good.
You're not a bother, okay? Please speak up. That's what we're here for, to learn. If I didn't want to be here, I wouldn't be here. No one's forcing me to be here. All right, so discharge needs. What kind of discharge needs is this patient with the broken hip going to have?
Probably therapy. She's gonna need therapy after discharge.
Yeah, I think she's gonna need therapy.
Okay, so you would want to give her a referral for physical therapy. What else?
Occupational therapy.
Occupational therapy, I put it too because
Okay, good. What else?
and
Oh, safety. She would need to be
Safety.
educated about safety in the home.
Okay, especially on using what?
Devices like a cane or a walker.
Okay, and she might need some sort of transferring device as well if she's not able to transfer on her own.
Right.
What else?
Medication teaching.
Okay, because she's complaining of dizziness, and that could be related to that drug that she's on for that osteoporosis.
Right.
yes.
Okay, what else?
She need a good diet and a good hydration. That's what I'm thinking.
Okay, she needs a good diet for a couple of reasons. One, she wants to try to conform that dietary towards that osteoporosis, right? So maybe increase some of those foods that have calcium, maybe increase some of those foods that have vitamin D. She might even have to take something with vitamin D or something in it. And hydration also. Also teach her about that medication she's on because maybe she's not aware of the side effects, and maybe teach her about the osteoporosis itself and some measures that she might need to follow. So those are all good things. We might also have to send out a home health aide, okay? A home health nurse, I mean, because she would go in the house and she's going to ask a series of questions. So some of those questions we ask when we go in the home are, you able to shop and get groceries on your own? Do you have enough money? Do you eat by yourself or with someone else? What kind of beverages do you consume at dinner time? Because, old people like to drink two things, alcohol and coffee. So we want to make sure that they're taking in the right, things that are going to promote healing and also reduce their risk for falling because, alcohol plays a little bit of part in that also. All right, so non-observable behaviors. So what are those?
I was putting like a pen.
Okay, pain's good, but I want you to understand that it's what the patient tells us. So the patient
Yes.
says, I'm nauseous. The patient says, I have pain. The patient says, I'm scared. Whatever that patient says that they tell you, that's the subjective. So this patient is actually moaning and groaning. She's telling you she has pain 2 out of 10. Anything else that she's telling you. And that observable is what you can see. So you can see on the x-ray that she has a left hip fracture. That's observable. Her vital signs are observable. If the leg's externally rotated or shorter than the other one, that's observable. Now, where it says stimuli, focal, contextual, residual, you're going to actually copy and paste what you put in those boxes above right into here. It's the same focal, contextual, residual information. Now, if the patient already has something, they're not at risk for it, okay? So for this patient, let's just talk about knowledge deficit. You can talk about your own diagnosis because she's gonna have some diagnoses. She's at risk for falls. She has impaired mobility already.
Miss Sue, because she fell already. Can I put she's at risk? Like a
You
risk
can
for
put the
fall?
risk for fall. You can use that one because with the risk for fall, you can still fall again.
Yeah, that's what I'm thinking. Yes.
Yes. But if she had an infection, you wouldn't put risk for infection because she already has the infection. And like if you're going to use knowledge deficit in relation to the osteoporosis, it would just be knowledge deficit. It wouldn't be risk for. Now, when you do the risk for, you really only need that two-part statement, the risk and what's causing the risk. All right. But if you look at this care plan at the bottom where it says knowledge deficit, that's an actual nursing diagnosis. Okay, so her knowledge deficit is for this patient is related to the wound care. All right, and it's evidenced by the patient not being able to identify the signs and symptoms of infection or being able to perform that aseptic technique when performing the wound care. So now your interventions and your goals, everything should be married together here. All that should correlate towards that nursing diagnosis. So here, you're going to have one priority nursing diagnosis. You're going to list 3. One of them is going to be priority. Put the one that's priority at the top. Where it says nursing interventions and rationales, those are all going to be catered towards that priority nursing diagnosis, not towards the other 2. The other 2 are just there for decoration. Okay? Because more than likely your client's going to have more than one problem, but you're only going to address one problem in the care plan. All right. So for this, let's say we were addressing the knowledge deficit about the wound care. So what are some goals and interventions that go together that we would want this patient to do to increase their knowledge? Because if they increase their knowledge about how to care for the wound,
Put that down
then
beside
the wound-
yours. Tell Papa I said hello.
hello, can you mute, please? Then their wound's going to heal better, right? So, interventions, and you have to have 5 interventions and 5 rationales that are geared towards that priority nursing diagnosis. All right, so if I teach the patient aseptic technique, is that going to help with the knowledge deficit about that wound care?
Yes.
Okay, good, it will. How about referring them to a nutritionist? Would that help?
Yes.
Okay,
Yes,
'cause
yes.
it's
I put that
better.
one.
Yep, it's going to heal better if we're eating properly and we're not smoking. It's going to heal better. How about assess for redness, draining, and swelling? Would we do that? Would that be
Yes.
part of the knowledge? Okay,
Yes.
good. The next one is teach patient how to monitor wound to prevent infection, which is basically kind of the same thing, except this one says to prevent additional skin breakdown. So it is kind of the same intervention, but it's a little bit different. So I'm okay with that. And then monitor the white blood cell count to prevent possible infection. Now that's something we could do as the nurse, but it's not a goal we could give the patient really. All right, because they're not going to be able to monitor their own white blood cell count. Now, underneath where it says nursing diagnosis, there's another column. It says patient care outcomes, short and long term. All right, these are your goals. So your goals are going to be similar to your interventions, because whatever I'm teaching the patient, I'm going to want them to do when they go home, so that I have continuity of care, and whatever goal I started them out, it continues to show improvements and good outcomes. So everything has to be married together. It all has to go along, right? When your husband wears a purple suit to the wedding, you're not going to wear something that is totally not color coordinated with that suit. Somewhere either in your accessories or in your dress or in your shoes, you're going to have something that matches that suit, right? So most of the time you want to color coordinate when you're trying to look cute, right?
Right.
So you got to coordinate
Yes.
your care plan, right? You got to coordinate it so that everything goes together, so that all the goals are directed at achieving one mutual outcome. So if my intervention is to teach the patient the aseptic technique, I would want the patient to be able to demonstrate that they can complete the wound dressing using aseptic technique or the wound care. But I can't just say patient will be able to demonstrate wound care using aseptic technique. I have to give a time frame on it. So I would say maybe I would give the patient 3 days of training, right? Because you're going to have to teach this to them more than once usually. So I would say by, let's say today's the 20th, I would say by 9/28, patient will be able to demonstrate proper wound care using aseptic technique. Now I have a specific and measurable goal, and it's a short-term goal, and it's catered towards my nursing diagnosis, which says my patient has a knowledge deficit related to this wound care. So now I can give them something to do to improve that knowledge and possibly either enhance the healing of this wound or prevent other wounds from occurring. So another goal, another intervention I said was refer the patient to nutritionists, so patient can take in proper nutrients to enhance proper wound healing. So that's my intervention as the nurse. Now, what would I want the patient to do? Patient will be able to identify at least 2 foods that would assist in proper wound healing by the end of the shift, or by however long you think it'll take, within 1 week, or by 9/16/28. Because now I have a specific, measurable, attainable goal that I can go back and look to see, was the patient able to achieve this? Now let's look at evaluation. Okay, so my goal was that patient will be able to demonstrate proper wound care using aseptic technique by 9/28. So now I'm evaluating that. Was the patient able to do that or not? It's that simple. If they were able to do it, then I would say goal met. Patient able to complete proper wound care using aseptic technique by 9/28/20. 21. Let's say the patient wasn't able to do it by then, but they're working towards that goal and they're pretty close. So now I could say goal not met, patient not able to demonstrate proper wound care using aseptic technique by 9/28/21. So now I have to modify that goal. So I'm either going to give the patient more time to do it, or maybe the goal is too complicated for my patient. So I have to give them a different type of goal. Same thing, nutritionist, okay? Patient will be able to identify at least 2 types of food by the end of the shift that would assist in wound healing. Okay? Goal met. Patient able to identify 2 types of food to assist in wound healing by the end of the shift. Now I have to have 2 short-term goals. So short-term goals are usually those goals that the patient's going to meet while they're in the hospital, because they're only going to be there a day or 2 most of the time. Long-term goal could be patient will make outside appointment with nutritionist after discharge. Or like you said, one of the goals would be for your patient to have physical therapy for the osteoporosis. So I would want to make sure that Ms. Jacobson understood that she had to make an appointment with that physical therapy after discharge. So I would say patient will make appointment to meet with to meet with physical therapist within 1 week of discharge. So that's a clear, specific, measurable, long-term goal. And then if I'm the case manager, I could always follow up with the patient to find out if they actually did meet that goal. Does that make sense? Everybody understand that?
Yes.
And then references. You have to have references, okay? So let's say that for Elizabeth, or whatever her name is, Ms. Jacobson, Edith Jacobson, I decided that I wanted to use impaired mobility.
Miss Sue, how many short-term and long-term goals we have to put? 1 and 1 in each?
2 short-term, 1 long-term.
2 short, 1 long.
So I just typed impaired mobility into my browser and I'm going to hit search. Can you guys see my Google page?
Yes.
I like to use nurseslabs.com. It's a real easy place to go. So if you click on Nurses Labs, you see it there. It's on my Google screen. You see it says impaired physical mobility nursing care plan. So that's going to take me right to the care plan. And there it is. Can you see it?
Yes.
Okay, now if you scroll down towards the bottom, it tells you some of the characteristics that should be part of your assessment if you're using this diagnosis. One of them is inability to transfer, okay? Or limited range of motion, which she has both, right? So this is a good nursing diagnosis for this patient. What would be goals and outcomes? Now, remember, this is a standardized plan of care, so you need to make it unique to your individual. But your goals are going to be to avoid any hazards of immobility, prevent dependent disabilities, okay, because now she's going to be dependent, right? Help the patient restore, preserve, or maintain that mobility and function and independence. And here's some of the things. The patient will be able to do this physical activity independently. They would be able to demonstrate measures to increase their mobility. So these are some of the things. Demonstrate the ability to use the adaptive device, which she's wasn't doing previously, right? Which is why she fell. Oh, and look, our disease is down here too, osteoporosis. Here you have nursing assessments that you can do with rationales. Here's your nursing interventions with the rationales. You need 5. You got 5 at least right here with the rationales. And then references are right there at the bottom. You can also, for my students, I'm good if you just copy this link in the top of the browser. Make sure you on this page when you copy it, because when you copy that link from the top of the browser and just paste it in the bottom and say references, okay, it puts it right into a mode where I can just click on that link and it brings me right to the care plan so I can see where you got it from. All right, so that's at nurseslabs.com. All right, let's see if Edith Jacobson is going to work for us now. Anybody have any other questions about that? All right, you should be able to see Edith now, right?
Yes.
So again, we already went through the electronic health record, okay? So now we're going into the actual patient's room. So you always got to start with safety, okay? So you're going to wash your hands as soon as you go into the room. Let's see if we can get some sound going here.
I'll wash my hands.
Then introduce yourself.
Hi, I'm Amy. I'll be your primary nurse today.
Hi,
All under safety.
nice to meet you.
Identify the patient.
Please state your name and date of birth.
My name is Edith Jacobson. I was born on September 20th, 1936.
Now this is all telling you about
matches.
her mood, her level of consciousness, all that. After this, you can go to interventions or assessments. Okay, we're going to go to assessments first. And vital signs.
I'm going to take your temperature.
Okay.
The temperature is 99. She is breathing at 15 breaths per minute. The chest is moving equally. I'm going to check your pulse here in your arm.
Okay.
The pulse is strong, 90 per minute and regular. I need to check your blood pressure. You will feel tightness around your arm as I inflate the cuff.
Okay.
The blood pressure is 134 over 80 millimeter mercury. This is a pulse oximeter, which monitors the oxygen level in your blood. It fits snugly around your finger, but should not hurt.
Okay.
Okay, I'm going to ask her about pain.
Do you have any pain?
My leg hurts a bit.
When did the pain start?
After I fell last evening.
Where does it hurt?
In my left leg.
Can you describe the pain?
It hurts in my left hip, and it hurts to move.
Does anything make the pain worse?
Any movement, really.
Does anything make the pain better?
No, nothing really makes me better.
How would you rate your pain on a scale of 0 to 10?
Not too bad. It's about a 2.
Do you need something for the pain?
No, it is not that bad now.
I'm just going to ask her about allergies because in here somewhere they like us to ask her about allergies.
Are you allergic to anything?
No, I'm not allergic to anything.
Okay, so now I'm going to do a little bit of assessment. We're going to go to the, I'll go to head to toe. We'll listen to her heart and lungs.
I need to listen to your lung sounds with my stethoscope.
Okay.
The breath sounds are clear and equal bilaterally. Please try to be still as I listen to your heart sounds with my stethoscope.
Okay.
The heart rate and rhythm are regular without murmurs.
Then I'm going to do the neuro assessment. You really just have to do the legs. So we're going to do this one all the way on the right.
Neurological examination on you.
Okay.
The patient is conscious. Muscle strength is normal in upper extremities and right leg. Left leg is not checked for strength. There is normal sensation in all limbs.
So she has an order for anti-embolism stockings. I'm gonna put those on. I'm not sure what it's under, so we're gonna look.
I cannot do that right now.
Okay.
Her
she
stocking
can't
is
do it.
already on.
Oh, okay. I think there was something that it gigged me for yesterday, so that's why I went there. All right. Anyway, you'll see this at the end when you look at the different things that you did or didn't do. And that was one of the things it cited me for yesterday. So let's go back here and finish our assessments. We have to assess the IV. So I think that is under maybe here.
Let me just assess your IV.
Now, Mike gigged me for not washing my hand and putting on
Okay.
gloves.
The site has no redness, swelling, infiltration, bleeding, or drainage. The dressing is dry and intact.
We have to reposition her. So to do that, you got to go where it says physician patient, and you got to call for a second nurse first.
I'm going to ask the secondary nurse to come help me with repositioning you on your side.
Okay.
The secondary nurse will be here. You can go ahead when needed.
So once she tells you the secondary nurse is there, you can go ahead and reposition. If you see this electronic chart blinking down here, it's blinking for a reason. I know it's been blinking for a while. Just click on it and see what it wants you to see. I don't know what it wants us to see, but it wants us to see something, probably in the orders. But she doesn't get any medication, so I'm not quite sure what it wants us to look at. Maybe something to do with those stockings. Everything else is already going there. All right, we're gonna go back and finish. We
I
have to
see.
do teaching with her on fall safety and education, and we have to reposition her. So we'll go back to interventions. Let's reposition her since the nurse is there. We're gonna put her on the right side since she has the left hip
I will now
fracture.
turn you on the right side. I will make sure your shoulders and hips are in a straight line so you will be more comfortable as I turn you using the draw sheet.
Okay. Sounds good.
I have adjusted your shoulder so you are not lying on it. I would like to talk to you about activities, safety, and fall risk.
Okay. But I can't get up by myself right now.
When you can get up from bed due to fall risk, it's important that you use a support person and your provided walker. We will leave your call lights so you can call for us when you need help with anything.
So when you're all done with everything you want to do in here, then you're gonna hit that patient handoff. And that's gonna give you a score. All right. Then if you look over here on the left and on the right, you'll see all the red stuff, okay? That we should have did, like we should have put gloves on, when you should have did it. If you go in the detailed view, it gives you more information. So once you do it the first time, you can either print that out or take a picture of it, and it'll kind of guide you along.
So Miss Sue, you said in order to see the score, we have to do click patient handoff, and then it'll show us our score.
Right, but the thing is, you want to be done with your scenario once you click that patient handoff, because once you get that score, you can't change it. But you can do it over again, but you have to do the whole thing over again. What'll happen is it's supposed to score your highest score. So whenever you do it, I suggest you take a screenshot of it. Okay, like it's showing my highest score as being 100%, right? When I close this out, it disappears wherever it went to. So now when I go back into Edith Jacobson, it's going to always show me at 100%. When you put it into the Canvas though, Canvas doesn't always show your more recent score. It might show an older one, but whenever you get on your highest score, just take a picture of it. We could still see it in Canvas. Like if you made 3 attempts and one was 62, one was 72, and one was 100, we'll be able to see that. But sometimes Canvas doesn't pull your score right. So whatever your highest score is, just take a screenshot for your own protection in case Canvas doesn't reveal that, okay?
Okay.
So if you notice when I launch my simulation again, it's going to say that I have 100% because that's the highest score I got. So even though I just got a 62 on it, it's still showing my highest score there as 100%. And that's what it's supposed to do. But when it pulls to Canvas, it doesn't always show your highest score. If your teacher's paying attention, they can go in there and find it. Any questions about that? Now you have to do the pre-sim. Okay, try to get the best score you can on it. You can do it over and over. The V-sim itself, you have to get at least a 75% or higher on this part. And then on the post-sim, we expect you to get 100%. And then you have to do the debriefing questions, and those have to be uploaded into Canvas. Anybody have questions? Anybody have questions about the care plan? Anybody have questions about math that came on late?
Can we do some math questions?
Sure.
Yes, thank you.
Miss Susan, I'm gonna
Miss
be logging
Susan?
off.
Okay, what I'm gonna do is I'm just gonna stop this share for a minute. I want to stop my recording so that I can put a different